Good afternoon, good morning, good evening to everybody. On behalf of AIG Hospital, on behalf of our Department of Anesthesia, Perioperative Medicine and Critical Care at AIG Hospital, at the outset, I would like to wish a very happy second day, second World Day Regional Anesthesia and Pain Medicine to each one of you from across the globe. Greetings from AIG Hospitals, greetings from our department. We have an interesting program lined up for today's webinar, and we are privileged to have a very renowned consultant anesthesiologist, Dr. Murli Tondebavi, as our guest moderator. To introduce Dr. Murli Tondebavi takes a lot of time because he's a very voluminous CV, but in brief, he is the Associate Dean of College of Indian Institute of Anesthesiologists, India. He is a consultant anesthesiologist in pain at Apollo Hospital, Bengaluru. And importantly, everybody in the India knows, but those across the globe, he has started the Indian Journal of Anesthesia podcast, a very famous series, and notably, he has interviewed almost nearly all the consultant anesthesiologists across the globe in the IGA podcast. He wears several hats outside anesthesia. He also runs a very podcast series of on luminary lounges where he dwells upon the lifestyles or the life stories of important people who have accomplished quite a lot in their life, and it's worthwhile looking at those podcasts. So I welcome Dr. Murli for today's webinar. Thank you. Thank you for being with us.
Thank you very much, sir. Thanks for the very kind introduction. I'm very happy to be a part of this wonderful program that you have lined up this afternoon. Thank you.
Thank you, Murli. I would also like to introduce our moderator. For some reason, our clinical head, Dr. Lakshmi, she is not well, she could not join. But Dr. Sneha is here with us, and along with Dr. Vijay Durga, the vibrant anesthesiologist of our department. They have offloaded me from my clinical work almost to a larger extent. Dr. Vijay Durga has a special interest in chronic pain as well as acute pain, and importantly, she is interested in pediatric anesthesia. She did masters from KIMS Hospital, and subsequently earlier she did diploma in anesthesia from Osmania Medical College. Dr. Sneha is also a consultant working with us for the past 3.5 years. She did her diploma in anesthesia. Subsequently, she did masters in anesthesia from Vellore, CMC Vellore, and subsequently she also cleared her ADAC recent past. She's special interests are difficult airways, pediatric anesthesia, and regional anesthesia. So over to you, Dr. Sneha and Dr. Vijaya. You can take this further, and all the best speakers. Thank you.
Hello. Hello. Hi, I welcome you all from the AIG Hospital Anesthesia Department. The first session is going to be held by Dr. Shruti. Dr. Shruti is a fellow in regional anesthesia with us at AIG Hospital Gachibowli campus. She is, her interests are in regional anesthesia, pain management, trauma management, and complex GI surgeries. Today she is going to present her first topic. It's on analgesia following total knee arthroplasty. Do we have any consensus regarding to it? Shruti, you can go ahead.
Good afternoon all. So today my topic is analgesia following total knee arthroplasty, and do we have a consensus regarding it? Total knee arthroplasty has been a prominent procedure that has been going on in all parts of the country and all parts of the world. And as the surgeries evolve, we've also evolved various anesthetic blocks and techniques to make the patient comfortable as they deal with the aftermath of the surgery and the pain that follows it. So first of all, I would like to welcome all of you from AIG Hospitals. Ours is Unit 2, which was started in 2018, while Unit 1 was started in 2003. It is an 800-bedded multi-specialty teaching hospital. In a year, we are doing approximately 13,500 surgeries, 60% of which are hepatobiliary and GI. Our team takes care of anesthesia and 64-bedded SCCU. Our department also runs the AORA Fellowship Program in regional anesthesia, of which I'm a part. The department also runs several research activities, and we have a state-of-the-art animal lab. We also have a dedicated PAC clinic, 8 a.m. to 8 p.m. in the OPD area for patient facilities. Also, we have introduced the acute post-surgical pain services, which is an APS team, which is also available 8 a.m. to 8 p.m. and also post 8 p.m. on call basis. NORA team, an airway team, and an OT anesthesia team, which takes care of 14 ORs, as well as a surgical critical care team, which takes care of our ICU. Coming back to our topic, so why do these knees hurt so much? And the million-dollar question, what do we take care of, the pain or the mobility? So we'll start with the basic innervation of the knee. Although it is a complex topic, I'm going to do it in crux and come to the basic innervation. This is the anterior as well as the posterior picture of the knee. So as we can see on the anterior aspect, on the medial side, we have saphenous nerve and the nerve to the vastus medialis. These are our two target areas when it comes to the adductor canal block. We also have the nerve to the vastus intermedius and lateralis, along with all our genicular nerve branches. All of these together are giving the nerve supply to the anterior, medial, as well as the posterior surface of the capsule of the knee. Commonly accepted methods of analgesia post-TKR. First of all is the femoral nerve block, which was the first introduced nerve block and was practiced. However, now we have reduced the usage of femoral nerve block post-TKR, and the reasons we are going to discuss in some details. Adductor canal block, which is a widely spread and accepted block post-TKR, along with some of its modifications. IPAC block, genicular nerve block, and the LIA or the local infiltrative analgesia, commonly done by the surgeons. So coming to the nerves which are targeted by our various nerve blocks. The adductor canal block, which is targeting the saphenous nerve and the nerve to the vastus medialis, the branches of the femoral nerve, and the popliteal plexus or the IPAC block. What is important about the IPAC block is that it provides analgesia to the posterior capsule of the knee. However, especially after the patients have been anesthetized and provided analgesia to the medial part and the anterior part, they tend to focus on this posterior part. So then we take care of it with this IPAC block, which we can also give pre-op for the patient to be comfortable. So the first nerve block that we'll discuss is the femoral nerve block. Here we see the femoral triangle and the femoral vessels, and on the lateral side we see the femoral nerve block. This is the LFCN. So here we see the femoral nerve, the femoral artery, and the femoral vein lying in the femoral triangle. The femoral nerve is seen lateral to the femoral vessels, and it is enveloped within the two layers of the fascia iliaca. This is important for us while we take the ultrasound picture, because while the nerve sits between the fascia iliaca two layers, we have to pierce the fascia iliaca to get to the nerve. The anesthesia provided by this block is the anterior and medial thigh, knee, medial leg, and foot. It can be used for surgeries of hip, knee, ankle, and patella quadriceps. So indications are surgeries of femur, patella, quadriceps, knee, and hip fractures for analgesia as well as anesthesia. This is our probe position. Usually we'll use a linear probe which is kept transverse over the femoral crease, and the needle tip is immediately adjacent to the lateral aspect of the femoral nerve between the two layers of the fascia iliaca. Volume required is 10 to 15 ml. This is a diagram which shows the fascia iliaca. Here we can see the femoral nerve which is sitting just beneath the layer of the fascia iliaca. It is usually enveloped within the two layers. Here's the artery and the iliacus muscle. This is our own scanning. Here also clearly you can see the femoral artery, the femoral nerve, and the fascia iliaca layer on top of it. So as for all nerve blocks, with the femoral nerve block also, never inject against high resistance. Circumferential spread is not necessary, and adjacent to posterolateral or anterior aspect of the nerve should suffice. Applying forceful pressure can compress the vein and can interfere with the spread of local anesthetic. This is when we are putting the transducer. It is not advisable to compress it with too much force to obliterate the vein, as it can distort the anatomy and therefore interfere with the spread of the local anesthetic. The femoral nerve is better visualized before the takeoff of deep artery of the thigh. So in the first image we can see the deep artery of the thigh, the femoral artery, and the femoral vein. So we should try and adjust our probe such that the femoral artery is visualized in our picture, but the DAT is not in it. Continuous catheter, although it can be placed in the femoral nerve, but it is not really recommended because the inguinal area is quite mobile and also shallow. So frequent catheter dislodgements can occur in this area. Complications of the femoral nerve block post TKR. So this is the reason why we have almost reduced the use of femoral nerve block as a mode of total of analgesia post TKR is quadriceps muscle strength loss. In this study, we have found that 67% of the patients who were provided with femoral nerve block have documented weakness by physiotherapists on post-op day 1. All of the patients had adequate strength by post-op day 2, which again continues to point towards the femoral nerve involvement in our block. 13 of these patients had post-op falls, and all of these falls occurred within 48 hours of the study. Femoral triangle block may be preferred over the femoral nerve block. So in case if we are going for the femoral nerve block, it is better to target the femoral triangle, which while involving the cutaneous branches may not affect the quadricep muscle as much as a proper femoral nerve block. So again we come back to the question of pain control versus mobility. So what is to be preferred, and why is this difference in opinion? This has led to the subsequent development of blocks, which is the adductor canal and the subsartorial block. This is the motor sparing version of the femoral nerve block and is widely accepted at this time and day for TKR surgeries and pain relief. This again we see the adductor canal and we see the saphenous nerve as well as the nerve to the vastus medialis. In the first slide that we have seen is the medial supply of the knee is supplied by both of these nerves. And therefore, it is important that we target both of them to get adequate analgesia. So here we see that the femoral canal and the adductor canals are lying in close proximity. So distal femoral block and the proximal adductor canal block, they are at the level of crossing of the adductor longus and the sartorius. Indications are analgesia post TKR. It can also be used in combination with sciatic nerve block for ankle and foot surgeries, ACL construction surgeries, saphenous vein stripping and harvesting. So again we come back to the adductor canal block. Typically we use the mid-thigh approach. The roof of the adductor canal is formed by the sartorius and the sides are formed by adductor longus medially and vastus laterally. It's a sensory block. But we have to be careful not to involve large volume because they can again cause partial motor block of the vastus medialis. Volume is around 15 to 20 ml. Probe is linear and transducer is transverse. Here again we can see the medial side of the knee supplied by both nerve to vastus medialis as well as the saphenous nerve. So what is important in this is that although both of them lie in close proximity, they are in different fascicles. Here we can see the sartorius, the adductor longus, vastus medialis. This is the femoral nerve, and this is where we target to achieve a nerve block of the both nerve to the saphenous as well as the nerve to vastus medialis. This is our scanning of the same picture. So the nerve to vastus medialis, problem why the difference occurs, that is in different patients the block is not working in the same amount of way or the reproducibility is suffering, is because the nerve to vastus medialis lies in a separate sheath which is the vasoadductor membrane. This we can see a cadaveric study. This is the saphenous nerve and this is the nerve to the vastus medialis, and they're both lying in separate sheaths. And therefore it is important mindfully to target both of them while we're giving the adductor canal block. This is medial vastus atrophy, which can be one of the complications, although rare, it's possible. So technique, it is typically performed at the mid-thigh level, 10 ml in the plane between sartorius and vastus medialis. More proximal approaches have potential for partial quadriceps weakness, as we have already discussed. So continuous nerve catheter, it is a good location for a nerve catheter, the adductor canal catheter. Ideally, we should aim to deliver local anesthetic to both the nerves, which is saphenous and the NVM. This is our picture where we can see the, I'm sorry for the poor quality of this picture, the femoral artery, the vein and the catheter, the nerve and the catheter. So modifications of the adductor canal block, certain modifications of this block have come in the picture now. One of which is the dual subsartorial block, where which is a hybrid form of the block targeting the distal femoral triangle as well as the proximal adductor canal. There's also an Indian block, which is the 4-in-1 block, which is a single technique injection and targets saphenous nerve, nerve to vastus medialis, tibial nerve, as well as the posterior branch of the obturator nerve. Coming to the IPAC, which is the interspace between the popliteal artery and the capsule of the knee. So it provides analgesia towards the posterior surface of the knee and can be given pre-op before the surgery. So we can use both linear and curvilinear transducers for this. USG guided infiltration of the posterior capsule, and it blocks the popliteal plexus at the back of the knee. Indication is back of knee pain post TKR. Volume is 20 ml. Complications of foot drop associated with higher volume. Probe can be either. Here we see the sciatic nerve, the popliteal vessels, and the head and the femur. In between the vessels and the femur is where we are trying to target the deposition of the local anesthetic. So it targets posterior knee pain, intra-articular nerves, and these are all branches of the popliteal plexus. So here is the scanning of the same. We can see this is the femur, the popliteal vessels, and here is where we are trying to deposit the local anesthesia. Now, the fourth block is genicular nerve blocks. This is derived from tibial, the genicular plexus, it is derived from tibial and common peroneal nerves. The deposition of 4 to 5 ml volume at each nerve is sufficient. It may be difficult to visualize it, but targeting the bottom slope of the femur may suffice on USG. Out of the plane or in plane approach can be used. It reduces post-op opioid consumption. So here we can see that we need to target 4 injections: superior medial genicular nerve, superior lateral genicular nerve, inferior medial. Inferior lateral should not be targeted because of the complications associated with foot drop. This is the 3-point injection technique that is used for genicular nerve blocks. Local infiltrative analgesia. So this is usually a preferred mode of the surgeons and not the anesthetists. And it is done by the surgeons, but reliability and reproducibility, it cannot be assessed. It depends on the individual person-to-person technique. Risk of intravascular injections are there. Risk of last is there. USG guided blocks, because they are safer, because they are more reproducible. So in conclusion, do we have a consensus for post-TKA? What we would say is one size doesn't fit all. So a femoral nerve block, while it works for a few people because of good analgesia, it does not. It also is associated with quadriceps weakness, and is not. And the future of the femoral nerve block in TKA is somewhat in a dilemma. So adductor canal, as of now, is an acceptable method in association with other methods such as IPAC. So it is used as a part of multimodal analgesia in combination with various motor sparing blocks. We have to target intra plus extra-articular blocks, or we have to combine anterior, medial, and posterior knee blocks. So why we are doing all of this is because it can help the patient ambulation in as less as 2 hours post-surgery. Because with evolution of our surgical skills and our patient care, we aim to discharge the patient as quickly as possible. It reduces opioid use, it improves patient comfort and well-being, and at all points we have to be mindful of the possibility of quad weakness and falls in ambulatory patients, especially because our target group in these surgeries tend to be the elderly. So that's all for this block. Thank you.
Shruti, that was a wonderful presentation. Thank you. I request Dr. Murali to give his expert comments on this session.
Yeah. It was an excellent presentation. In fact, covered most of the things in a very nice capsule, and the concept of even the multimodal approach was very nicely delineated. Any questions from the people sitting in the audience? I can see Karthik and others there. Anything to add?
Sir, is it okay if we take questions at the end of all 4 sessions, sir?
Yeah, fine. Because even I was thinking about the same, but I was thinking that we can get people to wake up in case they're planning to sleep in the afternoon post-lunch session. But it's a very good presentation. From the moderator side, do you have anything to add?
Uh, 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 No, sir, she has covered most of it. It has been presented
Yes.
as a multimodal treatment. And
Yeah,
now
yeah.
we are more towards using rectal canal and dual subsartorial even in our clinical practice because of the motor sparing actions, and our outcomes were really good. The patients are being pain free for the last at least 8 to 12 hours on an average.
Yeah.
Sorry, sir.
So I'll tell you a new thing that we are doing right now is we are also incorporating mindfulness-based practice now since the last 3 months. There was a paper in the Journal of Bone and Joint Surgery, which is famously called JBJS, which all the orthopedic people follow like, the Bible. So there was a study which came out from Harvard where they looked at mindfulness-based interventions in patients who had come with trauma and orthopedic surgery following trauma. And they found that the mindfulness-based intervention decreased the pain scores. And this was a very, very well conducted study in Harvard. And now they're conducting similar studies in shoulder surgery and also arthroplasty. So we did a pilot with our own program here. And in addition to whatever we are doing with regional anesthesia and multimodal approaches, we have found that this MBI also is adding value to the entire program. So that is something that probably we'll discuss in the coming year or so, because we are planning to do a study on that. But so far we have reached a stage where in regional anesthesia we're able to fine tune the blocks to such an extent that we're giving them good analgesia. And now we need to look at what else can we add to improve their satisfaction and outcomes. So that is something which I had to add. This is not regional anesthesia based, but we're looking at patient outcomes and patient satisfaction being better.
Thank you, Murli, for your wonderful comments. I'd just like to narrate the history of analgesia following TKAs in a hospital. In 2018, the surgeon was very hesitant for blocks, and he was quite comfortable with local infiltration analgesia for all his cases. And nearly, when we audited at the end of 6 months, 3 patients had near collapse within 30 minutes after the surgery, and mostly they had imminent symptoms of blast. So basically he was relying upon the dilution made by the nurse, and they took little higher concentration of bupivacaine instead of 0.25, 0.5%, which was overlooked. And then subsequently he continued to proceed with his favorite technique, infiltration. Then we said, why don't you try adductor canal block for a few cases? And then when he saw the difference, then he says he's now almost forgotten infiltration technique we are routinely giving. Then as and when we started the fellowship program, we evolved and we started practicing the pre-op IPAC with post-op dual subsartorial block, and patients were quite comfortable to the extent that the surgeon started requesting give one more block before shifting the patient to the ward. Because typically the adductor canal block duration lasts for about 10 to 12 hours, or depending sometimes a longer duration also. So then said, instead of poking twice, why don't we put catheters? Little hesitant he was, but subsequently one of the case was a redo TKR, and we put catheter. Patient was so comfortable. Now he is requesting catheter for all the cases. So I would say that it is just that you need to target the right area, and the surgeons are quite happy, and now they don't even ask what we do for the TKA patients. Yeah.
So we also evolved, sir. I mean to say we were initially, epidural days are probably 12, 13 years ago.
Yeah,
and initially it was femoral nerve block, and then later we had intrathecal morphine for a while, in addition to the femoral nerve block. And then IPAC since the past 7-8 years. And in addition, it's now adductor canal. It's not adductor canal, it's more of distal femoral triangle.
Yeah.
Again, if we become very specific and say we are going to give a DSB block, then again, everybody is giving, should be trained, should know the endpoints. And many of the obese patients that we get, it's very difficult to say which is actually the membrane, vasoadductor membrane, where is the fluid, where is it spreading. So we have kept it simple that we do a femoral, distal femoral triangle block. And now we also, in few patients, like a pilot, I tried cryoanalgesia of the genicular nerves. Didn't make much of a difference. We did around 20 patients, and RF of the genicular nerves in some patients, because they were related to some of the surgeons here, they requested that we do RF. The RF gave very good results, no pain at all. But considering it's a neuroablative technique and can lead to neuropathic pain itself, it is not something which is recommended as a routine practice. So I feel where we are right now is with LIA, with adductor canal or distal femoral triangle and an IPAC, along with the multimodal techniques like we give them Celebrex, celecoxib, starting free preoperatively. They were initially being given pregabalin, but then again there is no concrete evidence now with the recent meta-analysis that pregabalin is helpful for preventing pain or as an opioid sparing effect. So we don't know whether the earlier studies were flawed or whether there was something else going on. So this is where we are fine-tuned to give the best care for our patients. We will definitely have people for outliers who will have pain despite whatever we do, and identifying them early and intervening, as early as possible in the post-op period gives best outcomes.
What is your take on 4-in-1 block? This was a good paper published by Dr. Ritesh Roy from Bhubaneswar.
No. I haven't used 4-in-1 that much, but we do use HiPAC. See, all these are more or less related, sir. It's just a little bit different as to where we are putting the drug and how much we are putting. We do use HiPAC, but we reserve HiPAC for patients where we cannot give IPAC and where we would want the drugs. Example now, ACLs we use HiPAC. So we use a higher volume. We ensure we inject it in such a way that there is spread into the popliteal area as well. So there is a difference in, just a few differences in that entire area. So we get 5 or 6 blocks.
Okay.
So I think Ritesh would be the best person to ask actually, because he has published many papers and he follows it. But we don't do the 4-in-1. We just do a distal femoral triangle and we do the IPAC.
Okay. Thank you, Murli, for the comments. I think we can take more questions towards the end. Over to you.
Sure.
Our next speaker is Dr. Navya, consultant at AIG Hospital, and she has done her fellowship in regional and trauma anesthesia, and her area of interest are trauma resuscitation and difficult airway management. And she is going to present on paravertebrals and erector spinal plane blocks. Do they replace epidurals? Over to you.
Good afternoon, everyone. A very warm welcome to all of you. I'm Dr. Navya. Greetings from AIG Hospital. First of all, wishes for the second World Day of Regional Anesthesia and Pain Medicine. And I'm extremely thankful for this opportunity, for this contribution on this occasion. So to start off with, I have no conflicts of interest. Whatever images have been used from our institution with due consent of our volunteers and our patients. And wherever required, due credits have been given. So change is a force of nature. It's the constant flow, and we need to flow along with it. With the advent of regional anesthesia, with the beginning of discovery of cocaine and its usage in spinal anesthesia in late 19th century, we have seen a rampant evolution in regional anesthesia practices, changing our way of patient management. Now, as we are advancing from neuraxials like spinals and epidural to peripheral nerve blocks and facial pain blocks, and also we are seeing advancement from landmark guided techniques to facial pain to PNS guided techniques and ultrasound guided techniques. So with the technological advancements, our practices are also being refined. But this makes me think that do we need to abandon our old practices which are time tested and which were proven and which supported us when there was no advancement in technology? This is the thought that came into my mind when I was told to discuss about this topic. As we are moving from central to periphery, like for neuraxials, like epidural and spinal, towards chest wall and abdominal wall blocks, do we really need to take a pause, rethink and redefine our practices? While embracing the change of learning the nuances about the latest upcoming blocks, do we need to still hold our old techniques? Let's discuss further on it. First of all, I would like to discuss about paravertebral block. I like to call it a near twin when it's compared with epidural because of the anatomical location and also the quality of analgesia and anesthesia it has the potential to provide. I wouldn't be divulging into the extreme details of the block, but paravertebral blocks, most commonly we perform the thoracic paravertebral blocks. The levels are from T1 to T12, and paravertebral space is a wedge-shaped space in all the three dimensions, which is bounded medially by the vertebral body, intervertebral disc, and anterolaterally by the parietal pleura and the components of lung, and posterolaterally, which is important for us, the transverse process and the superior costotransverse ligament. It contains spinal nerves, white and gray rami communicants, and sympathetic chain, fat, and blood vessels. Now, because of sympathetic chain, it has the potential to provide visceral analgesia, and the vessels are also prone to puncture, causing hematoma. The indications range from acute pain management, as in case of rib fractures and chest traumas, and post-surgical pain management primarily for thoracoabdominal surgeries, and also for chronic pain management in case of neuropathic pain associated with ribs and cancer. Also, we have all the three landmark USG and PNS guided techniques available. Now, in short, there are two techniques of scanning, a transverse scanning and a parasagittal scanning. The idea is to deposit the local anesthetic agent in the paravertebral space, piercing the superior costotransverse ligament. You can give a single shot block with 15 ml of drug, or you can give multi-site block of 3 to 5 ml per site. The dosage in pediatric are volume based, about 0.2 to 0.3 ml per kg. Infusions, catheters can be placed, and the advantage is that the surgeon can place the catheters directly under vision after completion of surgery or after the before the thoracotomy, and infusion regimens can be followed. Now, what are the advantages of paravertebral block? So it is said that the learning curve is better. I might differ a little bit of it, because if you're considering a thoracic epidural to be difficult in terms of anatomy, I suppose for no ways, paravertebral block is also an advanced block, especially when you're trying to do with USG guidance. But when they started the landmark guided technique, approximately 1905, they used to hit the transverse process and walk off the needle, and it gave profound analgesia. When it compared to thoracic epidurals, the analgesia is comparable. One advantage of paravertebral blocks is they are unilateral and thus help us to provide site-specific analgesia or anesthesia. Complications are there, but they are less as compared to epidurals. There is no urinary retention, which aids early ambulation and helps and is in compliance with our ERAS protocol. Also, they have potential to decrease chronic pain as studied in breast cancer patients, and overall, by providing good analgesia, they overall decrease the opioid consumption and post-operative nausea and vomiting. So, now what are the disadvantages? Anticoagulation is still a contraindication. The failure rates are approximately 6.8 to 10%, which is comparable to epidural anesthesia, analgesia, and complications, though less, are still persistent. Epidural and intrathecal spread is well possible, especially with single shot blocks if you're giving it a high injection pressure, and with such volume, intrathecal spread may be disastrous. A volume-based block, so definitely is prone for local anesthetic systemic toxicity. Also, we are yet to reach a point where we can decide the best local anesthetic dose and concentration for these facial plane blocks and these high volume based blocks. Also, laterality, even if it's a advantage, it's also a disadvantage, especially in cases where bilateral anesthesia or analgesia needs to be provided. Multiple injections, multi-segmental injections and bilateral injections can be uncomfortable to the patient, especially if you're giving it for preemptive purposes. Now, what does the current evidence say? As compared to epidural blocks, the analgesia is definitely comparable. So, they are equivalent at this level. But when it comes to side effect profile, though they are still there, they are better as compared to the epidural anesthesia or analgesia. They are associated with improved respiratory function and overall decreased need of HDU and ICU beds, because we think that paravertebral blocks might require less vigilance. Maybe I would like to differ on this, because it's still a high volume based block, and with the advent of the facial plane blocks, we are giving high volumes, and maybe we are just masked by the fact that we can just relax after giving the block. But vigilance still is required. Also, the landmark guided techniques, the Sona anatomy is comparatively easier and safer as compared to thoracic epidurals. That's what the evidence says. Now next coming, a very favorite block, a versatile block of a lot of anesthetists all over the country probably. I would like it to call it jack of all trades and master of, let's see, the erector spinae plane block. So in 2016, when the erector spinae plane block was introduced for chronic pain purposes, it really gained popularity. It was included in the Plan A block because the anatomy is its strength. The ease of anatomy, the ease of administration of the block is good. And so its inclusion in Plan A block was involved due to its ease, so that non-regional anesthetists who are not very much experienced can practice. It can be practiced in ERs, and also they say that it's versatile from head to toe. But is it really versatile? So according to the evidence, I would personally prefer to restrict it for thoracoabdominal and spine surgeries. When it comes to shoulder and hip, that's what erector spinae plane block have been tried for. There are better blocks available. Also, again, the indication encompass from chronic pain management and acute pain management. So as I said, the anatomy is easy. Scan, hit, visualize the transverse process, hit the transverse process. A minimum of 10 ml of drug or 20 to 30 ml of drug per site can be given in an adult. Pediatric again is volume based. Roughly the spread is 2 to 3 segments above and below. Now when it comes to mechanism, whatever you read, the mechanism is still unclear. The basic spread is laterally in the erector spinae space, medially to the paravertebral spaces and probably the epidural spaces, and there are slits where there are communications so that the drug can spread. Also, locally it can involve the nociceptors like A delta and C fibers and of the ESP and fascia and provide analgesia. Also, systemic absorption of local anesthetic is also a plausible cause for the mechanism. So when it comes to erector spinae plane block, dorsal rami are consistently involved. But when it comes to ventral rami and paravertebral block, they are frequently but not always involved. Rest, when it comes to epidural involvement, it is extremely inconsistent. So what are the advantages of erector spinae plane block? The anatomy, it's the strongest quality. So the ease of administration in ERs, for people who are not very much experienced in advanced block can do this. It's considered as a superficial block, so in anticoagulant patients, in patients on anticoagulant, we can give it even in emergency without the worry of a formation of hematoma. Dorsal rami is frequently involved, so it's a good option for spine surgeries. Also can be given in daycare surgery. There are complications, but they are reduced as compared to the other two blocks. Also, laterality is also its strong point. Now, what are the disadvantages of erector spinae plane block? The first one is reproducibility. Because of inconsistent mechanism and not well defined, most of the studies are based on case studies, case reports. Not many RCTs have been done. So the reproducibility of analgesia in every patient is a question. Also, the mechanism is not correctly defined. It's a facial plane block, so there is always a fight between volume, concentration and duration. Also, high volume blocks, again the chances of local anesthetic systemic toxicity is there. Major complications still persist. As compared to other Plan A blocks, there is no direct site of action. Laterality, again, poking the patient multiple times, 2 times or for multiple segments is also an issue. Also, it's more towards the analgesic side rather than the anesthetic side. So what does the current evidence say when it comes to erector spinae plane block? So when compared to no block or a sham block or a local infiltration, erector spinae plane block works. But when you consider it in comparison with other blocks, we do have better blocks, especially as proven for breast surgeries where modified PEX has better efficiency. But one area where I would believe that erector spinae plane block works is spine surgeries, and also in emergency cases for rib fractures and minimally invasive thoracic surgeries. Overall, I would suggest erector spinae plain block is good for thoracoabdominal surgeries and should not be considered a versatile head-to-toe block. So to summarize, so what is our crux in it? The question is about paravertebral and ESP versus thoracic epidural. So as we are moving from center to periphery with our technological advances, what is happening is we are increasingly inventing motor sparing blocks. This aids early mobilization, no urinary retention, and thus helping aid our ERAS protocol. Moreover, moving from center to periphery is causing a site and procedure specific blocks and analgesic region to be given. But it is also, there is a fight between volume because the volumes are increasing, and the complications of increased volume as in decreased duration of action because decreased use of concentration of the drug, increased chances of local anesthetic systemic toxicity are still possible. Peripheral blocks are more compliant with ERAS protocol, and there is always a fight between analgesic versus anesthetic blocks. So, to summarize, can epidural be replaced by paravertebral and ESP? My answer is no. But do we need to completely abandon learning the nuances of the new blocks? No. So everything has its own place. So our approach when it comes to our analgesic and anesthetic practices should be tailor-made, cater to the patient according to the patient profile and procedure specific. Everyone has its own role, and the old is still good. With this, I'll conclude. We have AIG conclave on perioperative medicine on the 22nd and 23rd of March 2025. I invite you all. Thank you for the patient listening. With this, I'll end. Thank you.
Thank you, Dr. Navya, and it's a wonderful presentation. Dr. Murli, sir, do we have your valuable comments on this? Rectus spinae plain block and paravertebral plain blocks?
Yeah, in fact, it is a very good presentation. I would say that the way the flow and everything was, taken through time, it was very good. Thank you. Now, we know that the debate in every regional anesthesia conference is between this paravertebral and erector spinae. So generally, you'll have two very senior people debating and, I would say not fighting, but at least having a genuine debate there. And things have changed in the last 3 to 4 years about our understanding of what erector spinae is, the facial planes, how the drug spreads, and how things are kind of, evolving in our understanding. So, Navi, I just wanted to ask you, now you said epidural is still old as gold, and erector spinae and other things still need to be kept, but it should be catered to by the patient, by the condition, or whatever, by the situation. Now, when you say that, are you not saying that, again, regional anesthesia, from the concept of being an art to science, where we were moving, is again back to being an art? What's your take on that? Because now, again, you are giving the onus to the person who is deciding on that day. There is no guidelines now according to what you're saying.
Yes. So, regional anesthesia is definitely an art, but this is an art which should be supplemented with science also. So my approach when it comes to regional anesthesia is always involving patient. Just recently today I had a patient who refused for an epidural, but he was ready for a peripheral nerve blocks. And I wanted to give epidural because it was an extensive laparotomy, but he refused for it, and then we decided to go for a preemptive block. So in such cases, the old is still gold. Definitely, epidurals will give me profound anesthesia and analgesia postoperatively also. But what if such cases where I cannot give? So in those cases, definitely I need to have a plan B. Plan A, plan B, both can be peripheral nerve blocks or facial plane blocks and the neuraxials also. That's my take on it, sir.
Excellent. And do you know anything about what we call as non-inferiority trials?
I'm not aware of it, sir.
Okay, it's very simple. Now, say you have, why I'm saying this is it's a kind of a hot topic now. We know that epidural is considered the gold standard, right? So if you put an epidural, say now, as you said, for your patient, say upper abdominal incision at laparotomy, you are sure that if you get the epidural in and it starts working, considering the thoracic epidural has got a failure rate of up to 25%,
Yes.
so you're in the 75% and you've got it right, you know that the patient will be quite comfortable. You can go home and rest because the surgeon is not going to complain. Surgeon will have a peaceful night and the patient is also comfortable. So a non-inferiority trial is when you compare, say, a paravertebral block or a thoracic epidural. You are trying to prove that the paravertebral is not inferior to thoracic epidural. So now when you say erector spinae and you compare it to, let us say, a paravertebral, and you take paravertebral as a gold standard, so let's take for, say, chest wall trauma, you got a patient with 2 or 3 broken ribs on one side, you know that paravertebral is a kind of a gold standard, because if you put a paravertebral at that point, you know, a patient will be comfortable. But when you do an erector spinae, you are trying to prove that it is non-inferior to the paravertebral. So now this is quite a hot topic in research field, that people are trying to do more non-inferiority trials, and understanding how to interpret them is very important. And I think we will see a lot of development happening with the blood concentration levels with facial plane blocks, because that is something which again is being debated with whether the volume that you give in erector spinae is what is causing analgesia because of the systemic effect, not on the local neural effect. So the blood concentration of ropivacaine or bupivacaine going up is actually leading to analgesia rather than them acting on the nerves. So I think that's again something which is coming up. So these are the two things which, probably will evolve as we kind of go ahead in understanding. But otherwise, every year I think we're learning quite a lot of new things. So a very good presentation. Thank you.
Thank you, sir.
Thank you, Dr. Murli, for your wonderful inputs. Now I call upon the next speaker, Dr. Sirisha. Dr. Sirisha is a consultant at AIG Hospital. She has been with us for the last 5 years. She has done her fellowship in chronic pain management. Her areas of interest are in chronic pain as well as acute pain, and she's an expert in managing the high-risk cases. So today her topic she's going to present on hemodynamically compromised ASA grade 4 emergency patient with septic shock with an lower limb cellulitis planned for debridement. How do I manage?
Good afternoon, everyone. Coming to my presentation. So, hemodynamically compromised ASA 4 patients posted for with septic shock and lower limb cellulitis posted for emergency debridement. How do we manage? So most of the patients requiring emergency lower limb surgeries usually present with cellulitis, sepsis, MOTS, coagulopathy with already existing multiple comorbidities. So we have various options, and regional anesthesia has got an expanded role in the perioperative care of the patients undergoing lower limb surgeries. So neuraxial blockade provide effective analgesia, but certain fallouts are there. Preferred alternative, regional anesthesia is the preferred alternative to general anesthesia with already compromised cardiovascular respiratory system compromised patients. So regional anesthesia has got improved they have improved the peri-op outcomes of the ASA 3-4 patients and moribund sick patients. So we in our hospital on an average we does 8 to 10% of our cases per month, particularly ASA 3 and 4 patients. So various thigh, knee, foot debridements, ankle surgeries, fasciotomies, below knee amputations and above knee amputations. So they serve as a particular challenge to the anesthesiologists regarding their management. So coming to the risk stratification, most of the patients are like high risk patients with multiple comorbs, sepsis, ongoing coagulopathy, multi-organ dysfunction, on various inotropic support and even on ventilator support. So we focus on the goal-directed optimization of these patients before giving anesthesia anesthesia and minimizing the aspiration risk and tackling a physiologically difficult airway. So even during intubation, there might be so many complications during intubation because of the already compromised cardiovascular status of the patient. And executing the plan of the anesthesia, pain management with multimodal analgesia. So for example, a patient on dual inotropic support with hemodynamic instability, such kind of patients, we don't even shift the patient onto the OT table. On the bed only, we will intubate the patient and we give block for analgesia. And balanced approach with safe anesthesia for the extreme age patients and with already existing like peripheral vascular disease patients with collapsed circulation, respiratory compromised patients. So coming to the case scenario, so it's a morbidly obese patient posted for right leg cellulitis, emergency ebony amputation. So patient had multiple issues like septic shock with AKI and already existing AF with FVR with multi-organ dysfunction on oxygen therapy with 10 liters oxygen flow and drowsy though obeying commands. So the lab values are suggesting the significant elevated WBC count and thrombocytopenia and TROP-I positive with sinus tachycardia with ectopics, and the P-POSM predicted morbidity is 98.9% and mortality 77.1%. So and already patient is on dobutamine and NORAD support. So the choice of anesthesia for these kind of patients, depending on the clinical scenario, we can go with regional or GA combined with regional anesthesia for these kind of patients. So coming to the various pros and cons of different anesthesia options. So general anesthesia is always a backup plan, though it is not like due to its various disadvantages. So we usually don't prefer unless the patient is very like sick and moribund collapsing patient. And central neuraxial blockade, though it provides complete motor blockade and avoiding the complications of general anesthesia, it's not suitable for the patients on already existing inotropic support, profound hypotension and ASA4 patients. Peripheral nerve blockade, it has got the minimal morbidity, early mobilization, no need of any adjuvants or opioids, prolonged duration of post-op analgesia and no side effects of post-op nausea, vomiting and stable hemodynamics. And we prefer regional anesthesia routinely for such kind of sick patients. And coming to the excuse me, full screen. It's not working. Coming to the dermatomal supply of the lower limb, so the anterior part of the thigh is usually supplied by the L2, L3, L4, and the posterior lateral part of the knee and is supplied by the L5, and the S1 supplies the lateral thigh and the posterior lower leg, S2 the posterior thigh and lower limb, and S3 medial part of the buttock, S4 and S5 the perianal region. The muscular anatomy of the lower limb. So predominantly the anterior thigh part is supplied by the femoral nerve, obturator nerve supplies the medial part, and sciatic nerve the posterior and lateral part of the leg. Tibial branch supplies the posterior leg and plantar aspect of the foot, and the common peroneal nerve supplies the lateral part and the dorsum of the foot. Coming to the osseous sensory distribution, the femoral nerve supplies the femur bone in the anterior part, obturator nerve supplies the medial part of the femur, the sciatic nerve divides into the posterior and tibial nerve and common peroneal nerve that supplies the posterolateral part of the lower limb. The plantar aspect is supplied by the posterior tibial nerve, and the deep peroneal nerve supplies the dorsum of the foot. So for this patient, for this clinical scenario, so we prefer to give the femoral nerve block for the anterior coverage, lateral cutaneous nerve of the thigh for the lateral sensorial part, and obturator nerve for the medial, and sciatic nerve for the posterior and the lateral part of the lower limb. So we prepared the, we took very high risk concerned, and emergency crash cart is being kept ready, and like PNS and ultrasound guided, and local anesthetic and intra venous lipid emulsion. So we usually follow dual guidance technique where we integrate the nerve stimulation and ultrasound guidance to prevent the complications, and using PNS, peripheral nerve stimulator, can be helpful in those cases where the ultrasound guided visibility is poor due to technical or tissue related limitations. So coming to our block, so obturator nerve block, so we use curvy linear high frequency probe, and the patient is in supine position. So we supine position, we scan for femoral vessels initially, and we trace the probe medially to find the three muscles. One is adductor longus, brevis and magnus and pectineus, and the anterior branch of obturator nerve and posterior branch of obturator nerve. We deposit here around 10 to 15 ml of the local anesthetic drug. Coming to the sciatic nerve block, so we use low frequency curvilinear probe, where the probe is placed in between the near the gluteal crease of the patient. The position of the patient is in lateral position. So between the greater trochanter and ischial tuberosity, we can find a hypoechoic area between the gluteus maximus and quadratus femoral muscle, and we see a hyperechoic sciatic nerve, and we deposit around 20 ml of the local anesthetic here. Next block is lateral femoral cutaneous nerve for the lateral coverage of the thigh. So we trace the femoral vessel and trace the probe medially till the sartorius ends, and we find a wedge-shaped space where we can see a small hyperechoic lateral femoral cutaneous nerve. And femoral nerve, we trace femoral artery, and inferolaterally we can see the femoral nerve, and we deposit around 20 ml of the drug. So intraoperatively, the patient is comfortable, and the VAS score is almost 0. We continue the vasopressor support. Patient is hemodynamically stable, uneventful, and targeted goal-directed fluid resuscitation is done, and the patient got shifted to ICU with the same hemodynamics. And other newer modalities are continuous ultrasound guide. These are preferably done for a stable patient. Continuous ultrasound guided lumbar erector spinae block for thigh cellulitis, analgesia. So this article concludes that continuous ultrasound guided lumbar erector spinae block is an effective and safe alternative for analgesia of thigh cellulitis, providing pain control when added to the multimodal analgesia. Another one is parasacral ischial spine block for lower limb surgeries. So this block concludes that this can be a highly valuable addition for use in high-risk patients undergoing lower limb surgeries where we can't see the anatomy due to the edema of the lower limb. So this is a facial plane block. Without seeing the nerve, we can deposit the drug in the facial plane. So that's a good analgesia for such kind of patients. Thank you.
Thank you, Sirisha. I think all of us as an anesthetist, we get this kind of a scenario every day or once in 2 days where the patient with multiple comorbidities and in hemodynamic shock and in on dual vasopressor support. This is a very common scenario seen with lower limb fasciitis. As she has rightly said, the P-postmortem score with high scores, the predictive mortality and morbidity is also high. So in this case scenarios, regional anesthesia is like an very useful, and it helps us to prevent the morbidity in a significant way. But at the same time, we have to keep in mind, we have to resuscitate the patient. As we are a peri-op physicians, we need to continue resuscitation patient along with analgesia. So regional anesthesia alone might not suffice in these cases. We might need to do POCUS-guided optimization, POCUS-guided volume resuscitation, and all of these patients will even have physiologically compromised airways. Even a mere intubating might cause an cardiovascular arrest. For that matter, even mere shifting the patient from to the trolley on the bed can also cause a significant cardiac arrest. So for these scenarios, both the things have to go hand in hand. As she has mentioned, it's more of GA with regional anesthesia. So we have to give drugs to cause some amount of hypnosis and prevent awareness, and regional anesthesia will significantly help us to reduce the concentration of drugs and the amount of vasodilations and myocardial suppression the general anesthetic usually causes. In that way, the regional anesthesia helps us in a long way. Dr. Murali sir, your comments.
In fact, you summed up very nicely the role of focus, the role of resuscitation in addition to regional anesthesia techniques. So I don't think I have anything to add. And it's mainly a good, I would say, synopsis to youngsters as to how you should treat the patient as a whole and not just think about giving a block, because there are many instances where just giving the block patient actually might have arrested because other things are not being done. So that was very well highlighted. Thank you.
Murali, you hit the bullseye. I said the same thing to my colleague when she said that. See, basically, as a regional anesthesia fellow, you are so concentrated in blocking the nerve, giving the large volume anesthetic, but predominantly we forget that we are perioperative physicians, and resuscitation also is an important part of role of our anesthesiologists. So, not only to give analgesia, but also resuscitate and simultaneously give sensory-based analgesia where possible, so that you don't induce hemodynamic instability. So that is what we wanted to convey. Thank you very much for your comments. Yeah.
Next, I would like to call upon Dr. Shruti for the next session. The topic is nerve injury following peripheral nerve block. How do I approach?
Good afternoon. So, my topic now is peripheral nerve injuries and how do I approach. As a regional anesthesia fellow, this is something that is very important to me because regional anesthesia and peripheral nerve injuries go hand in hand. Not hand in hand, but this is something that we have to aim to avoid at all points of time. So first we'll start with the relevant anatomy. Nerve as an organ consists of the neural tissue, the connective tissue stroma, the designated blood supply. So nerve cell is mainly the cell body, the dendrite, the axon with its myelination, and the myelin sheath and the axon are bound by a thin layer of the connective tissue. This is the innermost layer, which is called as the endoneurium of the nerve. Outside the nerve fibers are then organized into groups which are referred to as the fascicles. The fascicles are surrounded by continuous and concentric layers of 8 to 18 cells or 7 to 20 nanometers, which is called as the perineurium. Group of fascicles bound together by the thickest of the three connective tissue layers, which is the epineurium. Epineurium is composed of collagen fibers and small number of blood vessels. This gives the nerve its characteristic external appearance on ultrasound, which we see as the honeycomb appearance or the hyperechoic nerve shadows. So this is one example of what we are not supposed to do. Here we can see intraneural injection of in the interscalene block. Classification of peripheral nerve injury. It is classified according to the relative degree of the axonal disruption. So the two most commonly used classifications are the Seddon and the Sutherland classifications. So the first one is neuropraxia, which is Sunderland type 1, where myelin damage is there, but the conduction and slowing are blocked, but prognosis is good. Axonotmesis, which is the loss of axonal continuity, but the endoneurium is intact, and neurotmesis, where the perineurium is intact. Going on to Sutherland level 4 and 5, we have breach of the perineurium and then the complete nerve transection. Mechanism of injury. So we can have various types of injury to the nerve. The most common and the most relevant to us is the mechanical or the injection injury. This also includes compression, stretch, laceration. It is postulated that the intraneural injection leads to sustained high intraneural pressure, which exceeds the capillary occlusion pressure. Eventually, it leads to nerve ischemia. Injection into the fascicles can also cause rupture of the perineurium and loss of the protective environment within the fascicle. Eventually, myelin and axonal disruption and degeneration. There can also be vascular and chemical injuries. Vascular injury is the local or diffuse ischemia that occurs when there is direct vascular injury or acute occlusion of the arterioles. This is the epineural circulation, this is basically the damage in the epineurium layer. So the epineurial circulation is the 50% of blood supply of the nerve. Factors which cause vessel puncture lead to hematoma formation, which mechanically compress fascicles within or outside the nerve sheath. Chemical injury can be because of local anesthesia, alcohols, phenols. Eventually, it causes inflammatory reaction and chronic fibrosis. It is postulated that the fragmentation of the DNA that is caused leads to disruption of the mitochondrial uncoupling and oxidative phosphorylation and eventual apoptosis of these cells. Inflammatory injury. One important thing for us to remember is that the use of ultrasound jelly can also lead to these kind of inflammation. This is proposed as mechanism for persistent phrenic nerve injury following the interscalene block for shoulder surgeries. Coming to the factors which affect the degree of the nerve damage, proximal versus distal PNI. Proximal sites such as the roots can be at a higher risk of injury compared to more distal sites. Needle tip. So this is a point of contention because it is said that the long bevel needles, though they are more likely to puncture and enter the fascicles, whenever we do have injury with short bevel needles, they will cause more damage in case of fascicular penetration. So along with these PNI related risk factors, we also have to consider some surgical and patient factors such as the positioning, the tourniquet for post-surgical inflammatory neuropathy, and patient factors such as pre-existing neuropathies. So how do we assess neurological complications? So most of the deficits that we will encounter in our clinical practice are sensory predominant and are limited in duration and severity. We can handle these with reassurance plus appropriate follow-ups. Some rare complications can require imaging, neurological or neurosurgical consultations. The injuries that are present or recognized late can have non-anesthetic or operative related causes. So patient characteristics such as pre-existing neurological diseases, diabetes, smoking, BMI, elderly, these also have to be considered while deciding for a peripheral nerve block. Peri-op characteristics of the needle associated with needle placement, pain while the injection is being given, prolonged tourniquet, positioning, sedated patient during block, and prolonged hospitalization can also in turn lead to more of PNI incidences. So documentation and recognition of these diseases are important. This brings us to our flowchart of how we deal with the PNIs. So are they limited to the common areas of compression? If yes, they are usually sent to pain management or neurological follow-up. If no, is the deficit in the block distribution? If yes, with mild sensory symptoms, we can go to neuro consultation. If it is progressive, eventually we have to go with inflammatory neuropathy and expedited workup. If no, then we go for EMG or nerve conduction studies at 3 weeks, neurological follow-ups, and if severe axonal loss may have to be referred to peripheral neurosurgeons. PNIs unrelated to nerve blocks also have to be kept in mind while we are evaluating any patient who has appeared with a peripheral nerve injury. So surgical tourniquet, post-surgical inflammatory pathway, surgical nerve injury, positioning, risk of immobilization, prolonged skin pressure, CRPS. So there is an interesting study that was done by our moderator, Dr. Mulli, which says that surgical tourniquet can be optimized in certain patients. So while using tourniquet, the Doppler was placed just below, and then just as the obliteration of the Doppler signals, more than 20% of that was used as a pressure for the tourniquet inflation. So this is a more objective method and can save some injuries in the post-op. Monitoring, documentation and consent is extremely important when it comes to PNIs. So the 3 musketeers that help us to perform safe blocks are the ultrasound, the nerve stimulation and injection pressure monitoring. So nerve stimulation has mostly replaced the paresthesia method of the nerve localization. Presence of motor response with less than 0.2 milliamperes is almost always associated with intraneural needle tip. So median minimal stimulation threshold was 0.6 outside the nerve and 0.3 milliamperes inside the nerve. Ultrasound. So as we are all proficient in handling ultrasound, we know what are the advantages. We can see the needle in real time. We can determine the distance from skin to target. We can see the deposition of local anesthesia in real time. We can diagnose intra-arterial tip, and eventually this leads to decreased incidence of blast. But we have to be careful. Just using the ultrasound itself is not a fail-safe mechanism. It is our vigilance while using the ultrasound that actually leads to safety while performing these procedures. Injection pressure monitoring. So more than 20 psi while giving the injection is almost always associated with intraneural injection. So less than 15 psi is ideal. Hand feel is the traditional method. However, now we have some newer techniques that have been introduced. One is the compressed air injection technique, and this is a commercially available manometer which are available to determine exact pressures while we are injecting our drugs. So documentation. In AIG, we are taking this documentation extremely seriously. We have an extensive audit board that has been prepared for these purposes. So here is the section that deals with our monthly PNBs and neuraxial blocks, where we are documenting the failed PNBs, failed SABs, regional converted to GA, failed epidurals, bed taps, last nerve injuries which are recovered, and other such unplanned intubation, ventilation in all of these cases. This is one section of our extensive dashboard. Fortunately, our rate of failed PNBs at the moment is 0.43%, and we aim to go even lower. These are examples of proper documentation while giving of the blocks. We should all aim to be very thorough with these kind of, with the procedure form fillings and documentations. So next presentation will be followed by my colleague Dr. Karthik, who is going to follow up about closed case reports following injuries of PNBs. Thank you.
Thank you, Shruti. Thank you for the wonderful presentation. So regarding the peripheral nerve injuries, our pre-op assessment at PAC, I think whenever we are giving any regional anesthesia also, we need to do a thorough examination of the patient, especially if they have chronic systemic conditions like diabetic, hypertension, which are most commonly associated with the peripheral nerve injuries. So if any of them are there, even they have pins and needle sensations or any neuropathies, we have to thoroughly examine the patient, do a detailed neurological examination, and note down the deficits. So that that will help us even in planning our anesthesia and in post-op, even if the patient develop, whether they are pre-existing deficits or they have extended beyond that, or it's a new onset deficit which has arisen because of our block. So we can differentiate, so that helps us in medico-legally also, and also in management of our cases. So second thing is a double crush injury. Already if there is an existing neuropathy, on the top of it we give a second hit to it, that will again cause more. Third issue we can do is regarding the adjuvants. If at all we are thinking there are neuropathies or at least a mild neuropathies, we would like to avoid adding adjuvants to the cocktail, whichever we are mixing, which we regularly add adjuvants to it for the prolonged block. Dr. Murali sir.
Yeah, this is one of the favorite topics that I like to discuss. So one of the things which I would like to highlight again for everyone is most of the injuries which are caused by regional anesthesia techniques are temporary in nature. So majority of the time it's about reassuring the patient and telling that things will get better. Second is we should not underestimate the other causes of nerve injury, like how we have mentioned about the pre-existing causes and the double crush effect. Also, we need to note the surgical causes for the nerve injury. So that's something that we have to keep in mind, and we should not take the blame entirely on ourselves, because the perioperative nerve injuries, only around 10 to 15% are caused by regional anesthesia techniques. So the remaining are caused due to various other factors. So that is something that we have to keep in mind, because I have personally come across anecdotally nerve injuries happening due to tourniquet, due to the surgical trauma, due to the POP and other casts that they put post-operatively. So there are multiple, even positioning. So if you're given a very dense block and the patient actually is in a position where the nerve is getting compressed. So let's take example, very nice interscalene block given for a shoulder surgery, but the arm sling being very loose and the patient's arm resting on the side rails of the bed can compress the radial nerve. So it can lead to a wrist drop post-operatively, and then the anesthetic is being blamed for a nerve block. So such kind of things also should be kept in mind. And as the speaker has already mentioned about using multiple modalities to prevent nerve injury, the more the better. So if you are going to be using ultrasound with a nerve stimulator, with a pressure monitor, I think that would be ideal. So things like this, to make things safer, always make sure that whenever starting the journey of regional anesthesia, safety is given more importance. Even if the block doesn't work, it's okay, but make sure that the patient has not been harmed. I would say that is the best way to look at it.
Thank you, Murli. I would just like to share one patient that we had a foot drop following, I think that was a single shot spinal, uneventful. And when we realized, when we did a root cause analysis, incidentally, interestingly, I would say, it was a tight stocking in the limb, lower limb, that was anti-DVT stocking that compressed the lateral peroneal nerve at the fibular head. It was a very tight stocking that the patient was put on, and that was the reason for compression. She recovered, of course. So whenever you are putting any stockings, especially above knee length stocking, they just gets uncurled, it just gets unfolded, and then sometimes it can form a tight constriction at the fibular head. So that has to be also be borne in mind whenever you are doing root cause analysis.
And another thing which I would like to mention is, more interesting than a lot of Netflix series are the case reports which talk about nerve injury. They're quite exciting to read.
So the next speaker, Dr. Karthik Chari, is a fellow in regional anesthesia at AIG Hospital with interest in airway management, regional anesthesia, and chronic pain. And he's a core member of IJA podcast team, social media ambassador for Aura 2024, and founder of Anesthesia Notes, a platform for supporting anesthesia education. And his topic is nerve injury following peripheral nerve block, close claim reports.
A very good afternoon, everyone. First and foremost, I would like to express my gratitude to ESRA, AORA, and AIG Hospitals for giving me this opportunity to be a part of this esteemed webinar on the World Regional Anesthesia Day. As a final speaker for today's event, I would like to shed some light on an important yet under-discussed topic, which is nerve injury following the peripheral nerve blocks. Let's discuss some close claim reports. I declare no conflicts of interest to disclose. And the key objectives for today's talk are understanding the prevalence and patterns of nerve injuries, learning from close claim reports to enhance the patient safety, and identifying the strategies to mitigate these risks. When it comes to nerves, they're fragile, handled with care. So firstly, what is a close claim report? So close claim reports are detailed analysis of malpractice claims that have been resolved either through a settlement, arbitration through a third party, or a court decision, and they are no longer open for a litigation. So the goals of analyzing the closed claim report are to identify the anesthesia related safety concerns, to know the patterns of injury of the peripheral nerve injury after the block, and the prevention strategies to mitigate these risks. Now, what is the incidence of nerve injury following a peripheral nerve block? There was a study conducted in between 1997 and 2007 with more than 380,000 cases over 10-year period in a single institution, and the result was the peripheral nerve injury frequency was about 0.03%. That was fortunate enough. Though the number is very less, but it is definitely significant and important. And the overall incidence of nerve injury following general anesthesia was again 0.04%, which was done under multiple specialties, and the peripheral nerve blocks had increased predominant by the brachial plexus. The most common nerve injury following peripheral nerve blocks, which was a study published in 2018 in Anesthesia and Analgesia journal, which showed a brachial plexus was the most common injury with 150 claims in 420. The incidence of nerve injury following peripheral nerve block. This is an Indian study published in 2019 in Neurology India journal, which again shows that the brachial plexus was the most common nerve injury. They have followed up post-procedure after the peripheral nerve injury was diagnosed. Most patients came with pain and motor weakness as their complaints, and functional recovery occurred in 8 out of 25 patients who have an injury after the supraclavicular block. There was an analysis made by Ramsey Baba et al. It was a medical legal analysis related to peripheral nerve injury, and they have found that interscalene block was the most common peripheral nerve block, resulting in litigation. In 2024, another study got published on the neurological injury after the peripheral nerve blocks. They named it as PBND, post-block neurological dysfunction, and surprisingly, they have found that the incidence has reduced from 1% to 0.3%, and again the incidence was highest with the interscalene block, even combined with other supraclavicular brachial plexus blocks. So after the closed claim analysis, from all the analysis, we have found that there are 3 categories that are potentially causing the peripheral nerve injury. They are anesthesia related factors, surgical related, and patient related. Anesthesia related factors resulting in around 17 to 19% of the cases only, and more than 80% of the nerve injuries were caused due to surgical and patient related factors. So the anesthesia factors are again intraneural injections of the local anesthetic, being it higher concentrations or mechanical damage to the perineurium during the technique, or high injection pressures. And also the local anesthetic neurotoxicity were there in a minimum of the cases. Moving on to the surgical factors, the main cause was the surgical traction, especially in the upper limb surgeries during the shoulder arthroscopy and also during the hip procedures. There was iatrogenic nerve injury during surgery, especially when it comes to elbow, where there is less of connective tissue or soft tissue. There is less protection for the nerves and more incidence of nerve injury. And also there is tonico-neuropathy, as already discussed before. The post-surgical inflammatory neuropathy is another predominant phenomena due to surgical factor. And also importantly, there is incidence of compression injury and vascular compromise when the nerve bundles are located very close proximity to the vascular bundles. And the patient factors included preoperative neurological deficit or neural compromise, and also the peripheral vascular disease, smoking, patients coming up with vitamin B12 deficiency, and medications like the antiretroviral therapy leading to the mitochondrial dysfunction and axonal degeneration after long-term use. These are all independent risk factors again for the perioperative nerve injury. As already discussed, there is a double crush theory or the double hit hypothesis, where the patient comes with a pre-existing peripheral nerve problem, for example like a diabetic neuropathy, where the diabetic nerves are less sensitive to the electrical stimulation. This theoretically increases the risk of intraneural needle placement when localizing the nerves using a peripheral nerve stimulator. So at these times, when the patient is already having a diabetic neuropathy and you give an insult with an injection into the intraneural component of the nerve, this is going to result in a double hit hypothesis and causing a compromise of the nerve. Let me discuss a few cases from the closed claim reports. Moving on to case 1, there was a 30-year-old patient undergoing a total knee arthroplasty. The surgery was done under femoral nerve block under ultrasound. The surgery and the procedure were uncomplicated, but later after the block wore off, the patient reported a decrease in the quadriceps strength. EMG and MRI were performed and the near complete loss of function of the femoral nerve was found. So concluding, the orthopedic surgeon noted a complete recovery from the nerve injury in 2 years, but the patient still claimed that he was not able to stand, squat or run, and that her knee buckled at times. So it was in the favor of the patient, and the surgeon had to pay, anesthesiologist had to pay $500,000 as a compensation. Moving on to case 2, there was a 28-year male. He was a status post humerus plating, came for implant removal So the technique used was interscalene block under ultrasound guidance, and a 24 ml of local anesthetic solution was used. Persistent inability to move the left shoulder and elbow was there, and also there was a decreased sensation over the shoulder, arm and lateral side of the forearm. This was happened beyond 48 hours of the procedure. So MRI was performed for diagnosis, and this featured brachial plexus injury involving the C5 and C6 roots. A full range of active movements with sensory and motor power regained in 7 months of follow-up. This follow-up included physiotherapy, electrical muscle stimulation and strength training, and patient regained about 80% of the deficit after the nerve injury. Is this because of dose-dependent neurotoxicity? And another case where a patient with a history of coronary artery bypass graft, he underwent a subacromial decompression and a rotator cuff repair, and the technique used was interscalene block under ultrasound. The procedure was again uncomplicated. A month later, he presented to the emergency department with shortness of breath, and later imaging was done which revealed an elevated hemidiaphragm with associated pulmonary edema and right lung base infiltrates. Pulmonology review was done where he told diaphragm elevation might be because of the nerve block, but later it was confirmed that the diaphragm injury may have been due to his cardiac surgery, and the case was ultimately dismissed and there was no settlement. And the next case, the patient underwent a popliteal fossa nerve block for the repair of the deformity of the left heel. A sciatic nerve block was used at the level of the popliteal fossa, and the drug volume of 50 ml of ropivacaine was given under ultrasound guidance. Again, the procedure was uneventful. Post-operatively, patient developed numbness and tingling of the toes and plantar surface of the foot. EMG showed a denervation of the associated muscles. What is the cause? Could be because of high drug volumes or lack of knowledge by the person who performing the procedure. And the last case was a patient who underwent an anterior tarsal tunnel syndrome. Technique was the popliteal nerve block, which was done again under ultrasound guidance. He had worsening of her pain and tingling post-operatively. But thing to know is that the patient had a massage 6 months back, and he was already a diagnosed case of tibial nerve neuropraxia, which was not documented during the pre-anesthetic checkup. So is it because the history was not known properly, no proper documentation, and should have been avoided giving block with known pre-existing nerve injury? That is something we need to think about. So this is our action plan. Whenever a block does not regress, we have our own plan to get a neurology consultation, especially the proper sequential documentation is done in a timeline so that the proper workup of the patient is done and the follow-up is done to see the resolution of the symptoms. Recently, we have done a survey on the nerve injuries following the peripheral nerve block, considering the very low closed claim analysis that was done in India. So we have decided that we can do a tiny survey so that asking all the anesthesiologists in India who are performing regional anesthesia to see like the incidence of nerve injuries and the contributing factors in the Indian onset. So we have asked them a few questions like block performed monthly. So most of them, the 33.3%, have told the blocks they have performed per month were 10 to 30, and the remaining performed between 30 and 50, like 20 to 22%. And what technique did they use to perform the peripheral nerve block? And most of them have answered ultrasound guidance. That is so fortunate enough. But most of them are also doing a landmark guided techniques. There is a this highlights the role in improving the patient safety. There is a need to shift from the landmark guided technique to a ultrasound guided techniques. In fact, a hybrid technique would always be better with the PNS and ultrasound going together. And what is the incidence of peripheral nerve injury following a peripheral nerve block? And 63.6% of the respondents reported having observed a peripheral nerve block following peripheral nerve injury following a block. This emphasizes the need for risk mitigation strategies in the regional anesthesia. And what is the most common peripheral nerve block associated with nerve injury they have encountered? And again, 48.5% of the respondents have given supraclavicular brachial plexus block as their answer. This highlights the need for importance of knowing the sonoanatomy, having a knowledge and technique, and being extra cautious while performing upper limb blocks. And what is the cause of nerve injury they have noted after peripheral nerve block? And it is mainly 36.4% contributed by the surgical related factors with compression related factors, mainly hematoma after the surgery, during the upper limb surgeries. This highlights the importance of documentation of the patient's pre-existing conditions like neuropathies and other neurological conditions. And what was the type of needle used to perform the nerve block? So majority use sharp needles, 50% of them, which are followed by blunt needles with 36.4%. And how was the nerve injury identified? Most of them were identified by the follow-up by anesthesiologists with a substantial contribution from the surgical teams. Here in our setup, we have a extensive ICU team and intensivist team, and also we have an APS team with acute pain services. So we are in regular follow-up with the patient till the patient gets discharged to home. That is how we follow up and be connected with the patient to see any new symptoms after a block. The diagnostic methods used. So the clinical diagnosis was the primary method for the evaluation of peripheral nerve injury in this survey, and which was followed by nerve conduction studies or additional insights. A nerve deficit following peripheral nerve block. So majority of the nerve deficits were transient, fortunately, and they have been resolved within a few hours or a very few days. And permanent sensory or motor deficits were not observed in this survey, which was done in India. We are very fortunate about this. So coming to the outcomes of the recovery following peripheral nerve injury, a complete resolution was seen in 63.6% of the patients, and a smaller one only reported the partial or no recovery. And to summarize, reliable and consistent data regarding the actual incidence of nerve injury has always been difficult to obtain given the subjectivity of the number of studies, though the permanent nerve damage is very less compared to the transient sensory or motor damage. Is it a high time for standardizing our regional anesthesia techniques universally? From the closed claim reports, here are a few take-home points. One is the needle tip localization under ultrasound, that is very important to prevent the intraneural injection, and using blunt needles preferably. Avoiding the needle trauma, iatrogenic injury to the perineurium, and usage of peripheral nerve stimulator, ultrasound, and the injection pressure monitor if available, with an opening pressures of less than 15 or less than 20 psi at least. And using of the optimum volume of the local anesthetic, especially in the patients where we discussed double crush injury can occur. A very important thing is documentation of the pre-existing metabolic, hereditary, toxic, or entrapment neuropathies of the patient is very, very important. In profoundly symptomatic neuropathy patients, it is important to limit the local anesthetic concentration, limit the dose, and avoid the use of adjuvant epinephrine, and maintain the needle tip distance from the nerve. Early recognition and appropriate management by follow-up is again very, very important. Discussion and counseling the patients regarding the potential risks and benefits of performing the peripheral nerve block is again important during taking an informed consent from the patient. Early diagnosis and early specialist consultation is very important once you notice the sensory or motor deficit after the nerve injury. That's all for today. Thank you so much.
Thank you, Karthik. It's a very nice presentation and is very informative. So documentation and taking consent is very important before performing a block, I feel. So Dr. Sunil, sir.
Yeah,
So Dr. Murali.
No, that was very well summarized. My only thing was I was surprised to see the first case, 30-year-old undergoing TKR. Karthik, you got anything to say about that?
This was a documented and reported case from the ASA closed claim report, sir.
No, I agree, but was there any indication as to why a 30-year-old was undergoing? It will be generally a post-traumatic, but was there any mention there?
Arthroplasty was mostly because of the meniscal tear or...
No.
It could be because of a meniscal injuries.
No, mostly it looks like post-traumatic.
Traumatic.
Post-traumatic, mostly
Yeah,
post-traumatic.
yeah.
Yes.
That was one, and very well presented. You highlighted a lot of very key concepts. Thanks a lot. It was very good.
So, any comments, Dr. Murli, for any questions for anybody? You can. I think few questions have come directly to your WhatsApp. May I request all the presenters to come to the podium, please?
वहीं पे पोडियम के पास. Thank you everyone, all the four of you. The lectures were very wonderful and we have learned a lot of new topics also. So the first few questions is towards Dr. Navya. They have asked choice of erector spinae block versus paravertebral versus epidural in the patient with spine deformity. If the patient have a pre-existing spine deformity coming for any analgesia, what is your choice of block?
So, when it comes to spine deformity, what I'm expecting is due to a kyphosis or a scoliotic spine. Scoliosis, let us take into consideration. So, in those cases, the vertebral bodies are rotated. So, I am not expecting to visualize the paravertebral space well. Also, since it's rotated, the muscles can be taut on one side. So, for erector spinae plane block also, the potential space might be lost. So in such cases, even though epidural are difficult, but with the help of USG guidance and expertise, if placed, they can guarantee me analgesia. So in patients with spine deformity, I will go for an epidural.
Sir, your comments on the same question, sir?
Yeah, and if you're putting a thoracic epidural, is there any specific technique that you choose, and how do you go about in a difficult spine?
In a difficult spine, I would we will basically select two or three vertebra, and we'll see according to the rotation, and mostly it will be along the convex border of the vertebra, and I'll use a USG guidance to place the epidural catheter.
No, that's what I wanted to know. How do you go about it? In the sense, are you using a midline approach? Are you doing a paramedian approach? And if you're doing, are you doing real time? Are you marking the transverse process? What is your technique?
It will be a paramedian approach.
And would that be real time, or you're just marking the transverse process there? Or because Shiva Shanmugam has and Archana, they have described a very good technique of doing it in real time.
Okay.
And I don't know whether you have seen the paper. It was actually published in RAPM, and there's a accompanying video also along with it.
In fact, we had a demonstration by Dr. Shiva Shanmugam and Dr. Archana when we did a live workshop here. Wonderful demonstration, real-time ultrasound. But we are not doing real-time neuroaxials yet. Perhaps we'll start soon.
Yeah, I think, sir, I just wanted to ask you, do you use paramedian technique or midline for thoracic epidurals?
Mostly paramedian, sir.
Paramedian. So I think ultrasound would be again a very good tool, especially little obese or deformed spine, because we'll be able to mark the transverse process, and once we mark the transverse process, we know exactly at what depth we need to go and how we can approach the spine. So that was one thing. And second, if you can see the paravertebral space, why would you not choose a paravertebral space, Navya?
Because as I said, the continuity of the spaces might be lost. So I can expect a patchy block effect, and failure rates can be increased in difficult spines. So my choice primarily for a difficult spine, non-operated difficult spine, would be an epidural.
Okay, no, I completely agree that if you can do an epidural, that would be the best thing. But also you can say that if you're able to see the space well with an ultrasound, you should be able to do a paravertebral or erector spine. I don't think there's a major contraindication to that. Sunil, sir, anything from your side?
Absolutely. When you have a deformed spine, all the techniques are going to be difficult. So if you are able to visualize paravertebral space, there is a unilateral surgery, like doesn't require bilateral analgesia, then and the space is well visualized, then why not? Paravertebral or rectus spine, why not? Yeah.
The next question is to Dr. Karthik. Why do you think interscalene block was reported as the most commonly injured nerve blocks?
Yes, in most of the reports, interscalene block was most commonly found as the most common nerve that was injured after the nerve block. I feel the reasons are, one thing is the proximity of the nerve. The nerve, it is the nerve roots we are targeting in the interscalene block, and so the interscalene nerves, they are closely packed as fascicles. So the dense packing of the fascicles leading to less connective tissue around the area. So there is less protection around the fascicles. That is one reason. And another reason is mostly surgical also, because interscalene blocks were high. But was it because of the technique of anesthesiologists, or is it because of the surgical iatrogenic injury to the vessels that led to an hematoma, which later led to a vascular compromise to the interscalene plexus, which led to the interscalene block? That we don't know. So these were the two reasons that profoundly maybe made it the most common nerve injury.
Sir, Dr. Murali, sir.
Yeah, I think one of the points I'll agree that the neural tissue is more than the connective tissue. Therefore, the impact of any kind of trauma to the nerve probably will have a more lasting effect, one. But more importantly, I feel because interscalene is shown as an easy block to do and superficial, and therefore you see the traffic lights sign and you inject between the red and the yellow, and it's taught in a very casual manner. The respect for the nerves is probably a little less compared to, say, you're doing parasacral approach to sciatic or a subgluteal approach. People think that it is a very easy block, it's very superficial. So the casual attitude towards approach towards these nerves is probably one of the reasons. And people tend to go very close and go in between the C5, C6 roots, which I feel shouldn't be done. So nowadays the teaching is that we go a little lower down to target the superior trunk, and we stay just outside the epimysium of the middle scalene, so that we are not entering into that sacred territory of the neural tissue. So I think if we respect this, probably will bring down the incidence of nerve injury in interscalene. And traction, Karthik, is what causes the interscalene injury. It is not injury to the vessels, because vessels, I don't think people would go there as surgeons. If they're doing a shoulder surgery, they wouldn't be injuring the vessels there, but it is a traction due to the arthroscopic requirement that can stretch these nerves and cause problem. And again, the very important thing is the ending of the dural sleeve. So the dural sleeve around the nerve root can actually extend up to around 3 to 4 centimeters from the foramen. So not appreciating that and going very close to the nerve root can cause an intrathecal spread of the local anesthetic also. So I think these are the main things when it comes to interscalene.
I agree with you, sir, and thank you for the insights.
Thanks.
Thank you, sir. And one more question for Dr. Navya. So what is the choice of analgesia in patient with bilateral rib fractures with patient on dual antiplatelets?
So it's rib fracture and I don't have time to optimize. So I would go for a bilateral erector spinae plain block or even catheters.
Dr. Murali?
Yeah, I agree. I mean to say, with a dual antiplatelet, nobody would even think of doing an epidural or even a paravertebral for that matter. So I agree with what she's saying. And putting a catheter and using again a multimodal approach will definitely help these patients. So an erector spinae with catheter and an infusion running for a few days with multimodal would be the best approach. There are also others who have done even a SAP block and they have put catheters, but erector spinae would be more safer.
Any other questions, Dr. Murali? I think these were the 4 questions that came to us. You would like to add anything more before we conclude our webinar?
No, sir, I think it was an excellent webinar. We covered a lot of ground here, and I think the presentations were excellent. So thanks for inviting me. Thank you.
Thank you, Dr. Murali, for being a part of our celebrations today. Again, I thank Dr. Elena Mocha and the Second World Day Regional Anesthesia and Pain Medicine Congress, sponsored by all the societies of regional anesthesia, the ESRA, the ASRA, the WFSA, the AORA, for giving us this privilege to conduct this webinar. I thank all the speakers for making a meaningful contribution, and moderators, you did a wonderful job. And last but not the least, Dr. Murali, you helped us quite a lot by coming as a guest speaker. We know your busy schedule for the day. The list at Apollo is quite hectic, but despite that, you took out 2 hours of your time. Thank you very much. I also like to thank the academic department of AIG Hospital, the audiovisual team, for providing us this auditorium for today's webinar. So with this, I conclude the session, and have a great evening and have a great week ahead. Thank you.
Thank you. Thank you very much, sir. Looking forward to meeting all of you in March.
Absolutely. We welcome you all to the Perioperative Medicine Congress that will be there in March. But before that, we are meeting next week.
Yes, sir. Definitely.
Thank you. Thank you so much.
Thank you. Thank you.
Thank you.